I'm Dr. Krishna Reddy, country leader for Access Health International. If you understand the India, almost 70% people pay out of the pockets. And health spending is one of the reasons for pushing people into poverty because of the catastrophic illness. So the only way that you can do that is protecting people against that, especially the vulnerable people, the socio-economically backward people. Ayushman Bharat is a continuation of what some of the states already initiated in this direction. For example, the Aragyashri in Andhra Pradesh and Telangana and a lot of other states introduced that scheme. However, a provision at a national level and covering virtually 50 to 60% of the population, that is in the right direction, especially giving the health protection. And one more aspect about Ayushman Bharat is the continuing expense out of hospital, because most of these are lifestyle diseases. It is not just fever, diarrhea, something like that. It is diabetes, heart disease, brain disease, kidney disease, which are lifetime diseases. So that means they need to spend money even out of the hospital. So that is where the other component of Ayushman Bharat is designed to address that issue. That means how do you actually prevent these diseases, and how do you provide affordable medicines for these people? How do you provide affordable diagnostics for these people? So the success of these two things will depend upon how well they are going to be implemented. Yeah, so there is a realization across the globe, while the emphasis in Millennium Development Goals and SDG, the Strategic Development Goals of United Nations, was towards universal health coverage. But the realization is that even though you make a protection, is the delivery system in a position to give you the safety people require, the quality that the patient deserve, and more importantly, the equity and the dignity. So they are calling it as now QED, quality, equity, dignity. So it's not just enough to provide only coverage, you need to equally give emphasis on quality, equity, and dignity. Yeah, so this is where the solution has to be looked at a system level. As a clinician, I can tell if somebody comes with a fever, somebody comes with a pain, I can give just a paracetamol or some pain relief medicine. But if I don't treat the underlying cause, I won't eliminate the disease. It will keep on coming with the same symptoms, same problems. So same thing, unless you fix, suppose you want to fix neonatal deaths, you want to fix tuberculosis, you want to fix malaria, unless you fix the entire system, especially those programmatic approach might have been relevant when it is mostly malnutrition and infectious diseases. But when we have already marched towards lifestyle diseases, so-called non-communicable diseases, now the recent data is 60%, 70% of deaths are due to non-communicable diseases. Here the entire system approach has to be there. So when I say entire system approach, there is a governance component of it, where health financing, health policy, health regulation, and there are payers, both public insurance, private insurance, employee insurance, and out of pocket. The third block is the provider system, hospital-based, community-based, formal, informal, traditional, modern. So it's a very complex, but if we can easily put into these blocks, and center of all these three blocks is the person and the family and the community. So all these four blocks have to be addressed in a parallel. So what has the potential to address all these things is the fragmented system which India has. The only thing that might enable to make it uniform and seamless a system is the information technology, or what today people are calling as digital health. India is at that cusp. We are able to provide universal health coverage. Now we had a heavy program of Digital India, and you have now one of the cheapest digital system in the world actually. Thanks to a lot of innovations recently in communications, almost last mile connectivity is also happened. So the country, in my personal view, is ripe for this transformation. So what the digital has transformed with reference to the personal identity, what it transformed with reference to the payment interface system, the unified UPI, Unified Payment Interface System, and what it could do to entire unification of our trading system across the country by the GST network. Without that digital network, it would not have been possible. So we have demonstrated, for a country of this size, we have demonstrated that we can do it. So if you can, digital is like Akash, the sky, which unites all the elements. Just like a human body, unless there is a neuronal system, you can't unite all the organs of the system, and they don't function in a seamless fashion. So our health system to work, the digital health has that capability, and we are arrived at that point. How it helps is, for example, a health policy maker is monitoring what is the health outcomes of the country. So the digital has the capacity to give you a live dashboard almost every day. The policymaker can get the data at a district officer level, a state officer level. I mean, that is how the GST is getting monitored today. What exactly is happening in each area of the country, how the small traders are getting affected. Can we make a policy improvement to that? So the responsiveness of the policy makers becomes much more agile when you have a live input of the data across the system. That's one. Secondly, the integration of hospital-based care and out-of-hospital-based care. Because unless it is integrated, unless it is interoperable, that means if I get a test done in some other place, when I go to other doctor, he will repeat the same test because he has no access to the data. He does not know that I have certain allergies to certain things. He does not know that what diagnosis I was suffering. And this shift can happen, like instead of hospitals owning the data, or the doctors owning the data and papers and other things, if the person is made owner of the data, then he will have the freedom to share the data with whichever provider he wants to go to. So Ayushman Bharat is interstate portability. Unless your health information also is portable, how do you actually expect this portability to happen? So our conviction at Access Health has been that the digital health as one of the key transformative engine can make it possible, be it driving quality in a provider side, or monitoring safety of a hospital system, or monitoring what is the cost it is incurring to deliver a service. For example, we are pricing Ayushman Bharat. But how are we pricing it? We don't know how much it actually costs to provide the service. And there may be, if you monitor different areas, some people may be providing the same service at a fraction of the cost because they have innovated. So that's why we said at a system level, the prescriptions that Access Health recently articulated through research and international collaboration, studying the best practices outside India, one is risk pooling. That means if you pool the risk of 1.3 billion people and have a single insurance or unified insurance system or unified payer system, you ask every vehicle to be insured. Why not every person to be insured? Make it mandatory, above poverty line. Below poverty line, let the government subsidize it or government pay for it. So there is a mechanism to make it global health insurance. So that is one, risk, what we call risk pooling. Second is strategic purchasing. That means as a payer, every housewife knows when she goes to shop, she wants the best quality at the least price. Right? But as an insurance payer, we never demand that. I am paying for every procedure that you do. Whether the procedure is a complication I am producing, I get paid. Right? So there is no output-based payment, that means performance-based payment. So there has to be a shift from input-based payment to output-based payment. So that is the second prescription that is there. But at the same time, as a payer, you also should price the services in a realistic fashion so that the provider, be it a private provider or a public provider, they should be sustainable, financially sustainable to provide at that price. For example, if I price bypass surgery at 50,000, I may not be sustainable. Then I will compromise on safety. I will use the least cost medicines, which may not be quality assured. So there is an interaction. So there has to be a trust between the payers and the providers. So this is the second prescription of, and also the payment has to be as per the promise. If I have promised to pay within 90 days, you have to pay within 90 days. The third thing, even the person has to be responsible for their own health. We ignore that aspect of it. So how do you make the person responsible for their own health? Suppose you are covered by insurance, you want under the sky. You want to stay longer in a 5-star hospital, you want to MRI for a headache, you want a MRI for a simple back pain. Because even the beneficiary, we have to ensure a system how he can be prevented from overusage and misuse of this thing. So fee-per-service system has to be disrupted to performance-based fee system. And a person has to be motivated or incentivized or even mandated to focus on preventing diseases rather than seeking help when he falls ill. Otherwise, they won't be responsible for their own health. Similarly, a simple social determinants of health like clean water, clean air, clean food, like Swachh Bharat is there. So Mission Bhagiratha in Telangana, aiming at providing drinking water to every household 24/7. That has a huge public health implication. Similarly, a clean gas to cooking. So indoor pollution kills many people than outdoor pollution, especially in the rural villages. So these are simple policy decisions which can actually save more lives than spending money on advanced complex surgical procedures which might be saving only 1 or 2 lives if you do for 100 people. So this is what I call a system level transformation. So it is not just addressing one aspect of it. So you need to address the person concerned, the governance system, the payer system, the provider system, and the digital integrating all these 4. I mean, this is how I could visualize how transformation is possible. Yeah, so in fact, I personally have been working in our own care hospital group system on the clinical governance side, because unlike other service industries, manufacturing and service, airlines, we talk of 6 sigma. That means 1 error per 1 million transactions. Healthcare, today it operates at less than 1 sigma. There are 12 mistakes per 100 transactions. Okay. So that is the level of inefficiency in our healthcare system. But using the same tools which other industries have used, process engineering, continuous quality, case and technology, is nothing but again systems approach to improving the delivery system. So you look at standardize the people component, their competencies, what are the processes a patient goes through the journey from womb to tomb. Can you standardize those processes, and can you standardize the protocols? If diabetes is there, can we standardize the protocols which majority of the people, so that there is no variation between doctor to doctor, hospital to hospital, whether it is a frontline health worker or a super specialist. A diabetes is diabetes, they should get the same treatment. So if you standardize those protocols and if you measure the performance, and for all these things, if you create an information technology platform to enable this system approach, we don't have to do for the entire system. If we just do 80-20 analysis, there are only 10 diseases or 10 illnesses presenting to the hospital which account for 80% of illnesses. So let us standardize those things. Same thing on the prevention side, like wellness clinics. How can we standardize how everybody should be screened above 30 years of age? How do we risk stratify them? How do we standardize the protocol when to start a statin, when to start a aspirin, when to start a ACE inhibitor to prevent a kidney disease? So these are easy to standardize. Idea is, we want to bring that same efficiency. So what we measure is, what is the quality we are giving, at what cost we are giving. So that quality per cost is equal to value. Okay. So quality again we measure in 3 dimensions. Is it safe? That is the first, because in medicine, do no harm is the first principle. Okay, that is a fundamental principle. Last 2000 years as a medical professional, doing no harm is the first principle. So safety is the paramount of thing. Then the outcomes that we are giving, is it as expected for the best outcome, or is, suppose if I do bypass surgery, if I am producing 5 deaths per 100 cases, it is better not to do bypass surgery, right? So outcomes we have to measure. The third is the quality which the person experiences. The person means including the family experience when they seek the health care. Cost has again 3 dimensions. What is the cost of actually delivering a service? I can manage diabetes in 50 rupees per month. We demonstrated that. But the same diabetes in another diabetic clinic, you maybe manage at 5,000 rupees per month or more actually. So how do we actually bring that cost efficiency in the system? Cost effectiveness is at a population level. If I do 100 people bypass surgery, is it cost effective? The same cost, if I invest into preventive care, I may be saving 10 times more lives. So that is at a population level, at a public level, financing level, we have to prioritize because we don't have unlimited money. Within the limited budget that we have, how to prioritize? There is no systems in the country to scientifically approach how to prioritize our spending. Even that 1.3% GDP spending, there is no scientific mechanism. How are we prioritizing it? Suppose if Ayushman Bharat says, I will fund cardiac transplantation. Is it a priority? No, because they same money, because you have limited money, you cannot supply. So these are some of the things we look at cost effectiveness. The third is cost to the payer, whoever is paying. Is it scientifically designed so that the payer or the provider are sustainable? So these are the measures, how we measure and drive the quality. And as I mentioned, strategic purchasing, for example, you have two methods, carrot and stick method. Either you regulate it or you incentivize it, or you nudge. Now recent theory is nudging theory. Okay, so you nudge, for example, Ayushman Bharat as a payer. So every empanelment of a hospital, they say that, okay, please checklist, do you have these basic quality systems in place, like fire safety or water safety, hand wash safety, air safety. So it does not take much time, right? It can be self-declared. You don't require somebody to inspect. You should have a follow-up audit mechanism. Same thing on the quality improvement also. Yes. So these are, I think, some of the things. I hope my arguments are convincing.